Autoimmune pancreatitis, or IP, is a rare form of chronic pancreatitis caused by the body's own immune system attacking the pancreas. Unlike typical pancreatitis caused by gallstones or alcohol, AIP is classified as an autoimmune disease. This means the body mistakenly identifies the pancreas as a threat and launches an immune response against it, leading to inflammation and damage. The exact cause of autoimmune pancreatitis is still not fully understood, but research suggests a combination of genetic predisposition and environmental triggers may be involved. Certain genes related to immune regulation are believed to increase susceptibility to AIP. Furthermore, some studies propose that molecular mimicry, where a foreign antigen resembles pancreatic tissue, could initiate the autoimmune response. However, more research is needed to confirm these hypotheses. In autoimmune pancreatitis, immune cells, primarily lymphocytes and plasma cells, infiltrate the pancreas. This infiltration causes inflammation, fibrosis, and ultimately damage to the pancreatic tissue. A characteristic feature is the presence of IgG4 positive plasma cells, a type of antibody-producing cell, in the affected tissue. This inflammation can lead to narrowing of the pancreatic duct, a condition known as stricture, and swelling of the pancreas itself. The immune attack also affects other organs in some cases, leading to systemic manifestations. Autoimmune pancreatitis is a relatively rare disease, and its exact prevalence is difficult to determine. It is more commonly diagnosed in middle-aged and elderly individuals, with most cases occurring between the ages of 50 and 70. IIP is slightly more prevalent in men than women. Due to its similarities with other pancreatic conditions, AIP is often underdiagnosed or misdiagnosed. The signs and symptoms of autoimmune pancreatitis can vary. Some individuals may experience abdominal pain, often mild and persistent. Others might have painless jaundice, a yellowing of the skin and eyes, due to bile duct obstruction. Weight loss, fatigue, and malabsorption due to pancreatic enzyme insufficiency are also common. In some cases, patients may develop new-onset diabetes mellitus. Because AIP can affect other organs, symptoms related to those organs, such as salivary gland enlargement or kidney problems, might also be present. Diagnosing autoimmune pancreatitis can be challenging due to its overlap with other pancreatic diseases, such as pancreatic cancer. The diagnostic process typically involves a combination of imaging studies, blood tests, and sometimes tissue biopsies. Imaging techniques like CT scans, MRI, and endoscopic ultrasound can reveal pancreatic enlargement, strictures, and other abnormalities. Blood tests assess IgG4 levels, which are often elevated in AP. However, an elevated IgG4 level isn't always specific to AIP. A pancreatic biopsy, either through endoscopic ultrasound or surgery, can confirm the diagnosis by revealing the characteristic lymphocytic infiltration in IgG4 positive plasma cells. Autoimmune pancreatitis is broadly classified into two main types, type 1 AIP and type 2 AIP. Type 1 AIP is associated with IgG4-related disease, a systemic condition that can affect multiple organs. It is characterized by elevated serum IgG4 levels and the presence of IgG4 positive plasma cells in affected tissues. Type 2 AIP, on the other hand, is not associated with IgG4-related disease and typically does not involve elevated serum IgG4 levels. Type 2 IP is often associated with inflammatory bowel disease. The primary treatment for autoimmune pancreatitis is corticosteroids, such as prednisone. These medications help suppress the immune system and reduce inflammation. Most patients experience a significant improvement in their symptoms with corticosteroid therapy. However, relapse is common after stopping corticosteroids, so some patients may require maintenance therapy with low-dose corticosteroids or other immunosuppressants like azathioprine or 6-mercaptopurine. In cases of bile duct obstruction, endoscopic stenting may be necessary to relieve the blockage. For patients with pancreatic enzyme insufficiency, pancreatic enzyme replacement therapy can improve digestion and nutrient absorption. Diabetes management is crucial for those who develop diabetes as a result of AIP. Currently, there is no known way to definitively prevent autoimmune pancreatitis. Since the exact cause is unknown, preventative measures are difficult to establish. However, maintaining a healthy lifestyle and avoiding known risk factors for pancreatitis in general, such as excessive alcohol consumption, can contribute to overall pancreatic health. The prognosis for autoimmune pancreatitis is generally good, especially with prompt diagnosis and treatment. Most patients respond well to corticosteroid therapy and experience resolution of their symptoms. However, relapses are common, and some patients may require long-term immunosuppression. Long-term complications such as pancreatic exocrine insufficiency or diabetes can occur. Recent research focuses on identifying biomarkers for early diagnosis and predicting treatment response. Studies are also investigating the role of genetic factors and environmental triggers in the development of AIP. Furthermore, clinical trials are exploring the efficacy of new immunosuppressive agents for managing AIP and preventing relapses.